So we have another Midwesterner who has come to California to make their impact in the world of otology and audiology. So it's Matthew Fitzgerald, who is up the road at Stanford, who is assistant professor of otolaryngology, head and neck surgery, and he's going to give us a talk today about cochlear implants and hearing. So thank you very much for joining us and taking the time out of your day.
Let's see, and I'm going to go ahead. We're back into share mode. Do we have everything?
Perfect.
Okay, I'm going to shift gears on you a little bit. Instead of talking on the implant domain, I'm going to talk about, about something a little different, which is actually kind of on how do we fundamentally alter what we do on a day-to-day practice in clinical audiology. So more specific, I'm going to talk about using speech and noise really in routine clinical practice, and what the implications are and what we can gain from doing this. So I've evolved a little bit my time at Stanford, just because I honestly saw the importance of this topic. So I still am very much in the implant world, but this is something that's been an increasing focus of mine in recent years. So I'll lead with the obligatory. In terms of disclosures, I have no conflicts of interest, no financial conflicts of interest here, and this research itself was funded by Stanford. So with that in mind, when I took this role as chief of audiology at Stanford, I had a lot of ideas, okay? And some of these things, of course, clinic has to run, but some of it is like, how do we push the field forward? How do we really think about, what do we need and how do we do something different? And so I always, in situations like this, I like to take a step back and say, okay, well, what do people think of when they think of audiology? And of course, the general thought process, as we say, well, it's the diagnosis and management of hearing and balance disorders. I mean, that's the easy statement. The thing is, when we look at what we do with the audiogram and with our balance assessments, these tests are largely diagnostic in nature. And of course, rehabilitative services are provided through hearing aids and cochlear implants. But when we talk about that diagnostic work, I mean, ultimately, everything we do boils down to, how well can you hear? What are your hearing thresholds? And then site of lesion. Where might the problem be if there is a problem in hearing? Okay, and those are certainly two very important tools, but I would argue these are incomplete tools. Okay, here's the thing, because audiologists and physicians and pretty much anyone that spends any time with patients are well aware that when an adult or a child may have issues kind of beyond hearing that can influence performance. Okay, and all you have to do is think, you can have individuals with the same degree of hearing loss, and one individual has tremendous difficulties functioning in the day-to-day world, and somebody else seems to move through okay. But the challenge is quantifying these sorts of issues, their effects on hearing performance. I just don't think the current test battery is really suited for that at all. And I think that's in large part because the audiologic test battery has not evolved. We are essentially been doing the same thing in many, many regards for, 30, 40, 50, 60, in some cases 70 years. And really, the focus has been continued on hearing thresholds and site of lesion testing that I would argue hasn't necessarily kept pace with medical practice. I mean, if you take a step back, you think large parts of the site of lesion test battery, or how many old audiology tests were done with the intent to trying to determine if something is a retrocochlear disorder versus just traditional presbycusis. And nowadays, if anybody gets a whiff of this, we're shifting to an MRI. Okay, so I would argue that audiology practice hasn't necessarily evolved in some ways as other parts of the medical practice has. So when I think about what should the future of diagnostic audiology be like, I view it from three big questions. Okay, so the first, of course, is how well does someone hear? This is absolutely crucial. This isn't going away. Audiometric thresholds, these are the gold standard for what we do. It's what everybody thinks about when we think about a hearing test. And absolutely, they're crucial for medical and rehabilitative management. But I would argue we could do more than this. And I would argue we should be doing more. And I'm going to show you a lot of data to demonstrate that we can do more and do so very readily. And in particular, I think we need to spend a lot of time thinking about how well does someone function with their available hearing, okay? And this question of function is, I would argue, largely missing from routine audiologic practice. But the thing is, perceived abilities on function, drive when patients seek care. And that's true for hearing aids, for cochlear implants. I mean, one of the biggest predictors of whether or not somebody comes in for hearing loss, is do they think they're having a problem? Okay. And thinking you have a problem is related to how well you actually function. And the thing is, you can't predict this from looking at the audiogram. Okay. We have to measure this. And what I'm going to show you data is that actually tests of auditory function are more sensitive to pathologies than the traditional test battery. And then the other part that I think that we're moving toward is how hard do you have to work to achieve that level of function? Okay, so the whole concept of listening effort. All right, now this is still kind of very much in the research domain, but this is I think this is new, but it's going to be an increasingly important part of it. But if we really want to capture the patient experience, we have to look at how well do they hear, how well do they function with their hearing, and how hard do you have to work to do it. And I really feel like it's a part of my mission is making sure that our routine test battery captures these issues, okay, as opposed to just, what somebody's pure tones look like. Okay. And I would argue that when it opens up a lot of doors, okay, in terms of when we start looking in particular at function, okay. I'm going to argue that because when we're doing this, we can tap into other variables that matter, cognitive factors. Okay, we know that one of the biggest predictors of cognitive decline in older adults is untreated hearing loss. Okay, but it's not like every patient with hearing loss develops cognitive issues. I think tests of function can better tap into this. I think we can get a better understanding of patient behavior and ultimately manage patients. Okay. Now, when we talk about assessing function, okay, and within audiology, I would argue that we really have two tools that are available to us, at least for potential clinical use, okay, that have potential to be meaningful in this regard. One, of course, is electrophysiology, and what I'm going to spend most of my time talking today is about speech and noise testing. Very briefly, when we talk about electrophysiology, and of course, the default thing that we think about is the auditory brainstem response. And just as a reminder, this is a series of obligatory potentials that occur within the brainstem, starting from this wave one is the first peak. This is basically the synapse of your inner hair cells onto your auditory nerve. And then a series of peaks, basically culminating up and through the inferior colliculus. And of course, we used to use this to help diagnose whether or not someone was at risk for vestibular schwannoma. Now this is used most heavily for assessing hearing thresholds in infants or children who can't respond. The thing is, your performance on an ABR really doesn't have any bearing on your ability to function in your day-to-day life. It doesn't relate to language development. It doesn't relate to speech understanding and noise, things of this sort. I'll tell you, I'm not going to talk about this today, but we've been looking at something called the frequency following response, okay, which is recorded the same way as the ABR. But what this is basically, it's a response within your brainstem that will phase lock to the period of a stimulus. So if you say, ah, okay, there's the fundamental frequency of your voice, there are certain fluctuations in that waveform, and your brain will actually phase lock to that. The thing is, how strong your brain achieves that phase locking ability is actually related to a whole host of things. And so, again, your speech and noise abilities, looks at language development, musical training, things of this sort. So it's kind of like a good measure of auditory health. And we actually published a paper a little over a year ago demonstrating that infants with high levels of bilirubin in the bloodstream, okay, have normal ABRs, but they have abnormal FFRs. And the strength of this frequency following response tracks largely with the bilirubin level. Okay, so that's great, but I'm going to spend the rest of my time today talking about speech and noise and why we need to be making speech and noise as our default test of auditory function. Okay, now normally the classic test for 70 years has been word recognition and quiet. And this is something that probably every single person on this Zoom thinks about when they think of, when you get an audiogram, what do I get? I get pure tones and I get word rec. Okay. The thing is, I'm going to argue that word rec is suboptimal for a lot of reasons. One, it's largely driven by your hearing thresholds. And if we look at things like a speech intelligibility index, which is basically how audible is the signal, you could predict the vast majority of word recognition just by straight up audibility. Is that signal audible or not? Thing is, we've been doing word rec since the late 40s. Okay, I mean, your PALPB list, the CNC word lists that we use for cochlear implant candidacy were first published in 1962. Okay, these things are based on the PALPB list, which were published in 1948. And the thing is, we've known since the mid 50s that there's no relationship between performance on your word recognition score and how people feel like they're communicating in the day-to-day life. And I would argue that, that this makes it largely insensitive to many pathologies. So we're used to seeing word rec, but I don't think if we were rebuilding the audiogram from scratch, this isn't the way we'd want to do it. Okay. And this is really underscores the problem here. Patients come into our clinic all the time. They say, Dr. Fitzgerald, I can't hear in background noise. Okay. And you say, yeah, that's right. Let me take you to this perfectly quiet room. Say the word bass. So there's this huge disconnect between what a patient says their problem is and what we're doing day to day on a clinical practice. And I figure anytime you see that type of disconnect, then that's an opportunity. So and this underscores the issue here. So what we've been doing at Stanford is trying to make speech and noise the default test of speech perception in the routine hearing test, with the goal of replacing word recognition and quiet. Okay, so I want to make that very clear. We're not trying to do speech noise in addition to word recognition and quiet. The goal is eventually to replace word recognition and quiet. And I'll give you a preview. We can pretty much, in a little bit, I'm going to show you some slides where we can pretty much predict what your performance in quiet is going to look like. And if I do that, that leads to guidelines. Anyway, figure like this underscores why it's so important to be thinking about speech and noise, and then why word rec is kind of less of an issue. What we're plotting here, this is data from almost 6,000 patients. On the x-axis is your word recognition score. So basically, what's your classic NU6 thing that we're used to seeing every day in the clinic? On the y-axis, this is your performance on a test we call the quick sim. So this is a speech and noise test. The output of this is not percent correct. The output of this is the signal to noise ratio at which listeners could identify 50% of keywords in these sentences. Okay, so we're moving away from like percent correct measures. We're moving towards signal to noise ratio based measures. Now, when we look at these measures like this, the data with the quicksand, according to the manual, they say anything with a signal to noise ratio of 3 or smaller would be considered to be normal performance in the quicksand. Quicksand values between 3 and 7 would be considered to be a mild deficit. 7 to 15 is a moderate deficit, and worse than 15 is considered to be a severe deficit. We're actually in the process of renorming this a little bit, but this was taken from the original published work from me and Kelly, and the suggestions there. But what's striking, so look at all these patients here with excellent word recognition scores, and some of them certainly do just fine and quiet, but many patients have significant difficulties understanding speech and noise despite having perfectly normal word recognition scores. I mean, pretty much all these people here have word recognition scores that are 88% or greater, which should be considered, excellent performance. Okay, yet well over 2/3 of these patients have a deficit understanding speech and noise. Okay, now that's no surprise to anybody talking with a patient, but to my mind, that says that there's a problem with this test, because right off the bat, we are not sensitive to what potentially the #1 complaint of patients coming through the door is when they have hearing loss. Okay. Now, if we look at word recognition scores, okay, across again almost 6,000 patients, what's interesting is the default assumption is yes, word rec gets worse with hearing loss, but I'll tell you, somebody has to have a lot of hearing loss before performance on word recognition scores really starts to fall apart. Let me show what I'm talking about here. So again, what we're doing is we're plotting, I've broken patients into different categories of their high frequency pure tone average. So this is basically, again, the high frequency pure tone average is the average at 1, 2, and 4K. And we picked that because that relates better to speech understanding than your traditional PTA. I'll tell you, when I analyze this with the regular PTA, I get the same thing. So what we can see here again, patients with rock normal hearing, borderline normal, mild losses, moderate, moderately severe, or severe to profound losses. And here I'm plotting all the individual data, and then the black line right here reflects what the mean performance is. So you can see, yes, on average, performance gets worse as we have more hearing loss. That's no shock there. But what's troubling is even patients who have a moderate amount of hearing loss, their average word recognition score is still over 90%. Okay, so again, these patients have a fair bit of difficulty hearing, but they're, on the whole, their word recognition is still quite good. And you see clearly there are some individuals who have difficulties, but by and large, it's still, you really have to start getting out to significant amounts of hearing loss before word recognition scores to start to deteriorate on average. Now, the score changes a little bit once we start looking at speech and noise. Okay, so here what we're doing is, again, I'm plotting speech and noise abilities as a function of degree of hearing loss. So again, so we're plotting high frequency pure tone average. Again, this is from very good all the way to basically to completely deaf. This is your quicksand. So again, good performance. Lower signal to noise ratios mean better performance. Worse signal to noise ratios mean, of course, worse performance. And again, anything above this dotted line to be considered to be normal performance, mild deficits, moderate deficits, and severe. So notice, of course, yes, on average, your quicksand score deteriorates with hearing loss, but there's a considerable amount of variability. And what's striking, even in patients with rock normal hearing, 1 out of 3 patients that we're seeing in our clinic with rock normal hearing still have a deficit understanding speech and noise. Okay. Now here, this is breaking down, looking at it kind of the same way with the word rec, where I've got it broken down by categories. Again, perfectly normal, borderline, mild, moderate, moderately severe, and severe to profound. And what you could see here is by the time we start basically, even borderline normal people are pretty much right on the edge between normal and mild amounts of hearing loss. Mild amounts of hearing loss, we're already seeing large, sizable deficits on quicksand, and it just gets worse and worse. So yes, performance on speech and noise gets worse with hearing loss. That's no shock. But the thing is that actually it's more closely tied to what your hearing loss is, albeit with a considerable amount of variability. I mean, you could see here these patients with moderate hearing loss, some of these people still do quite well in noise, and some of these individuals can't function at all. So this differs from word rec in that, word rec, you can still hold on pretty well, even if you're out with a moderate amount of hearing loss. With a quicksand, that is not the case. Okay. Now, what's striking here again, this to my mind is the sort of thing that makes me think that we can replace word recognition and quiet with speech and noise for the vast majority of patients and provide guidelines as to when word recognition is likely to be meaningful and should be measured. And that's really our ultimate goal here. You don't, in the same way that physicians don't order MRIs in every patient to come through. You pick the test based on what the history is and what the performance looks like. So, my argument would be that we should be doing word rec when we think it's likely to mean something. And word recognition is only likely to be meaningful, okay, if someone has more hearing loss and more difficulties understanding speech and noise. Now, why do I say that? So what I did is I broke patients with poor word recognition scores, and I used 75% as a breakpoint. And I looked at patients with better word recognition scores, okay? And what you can see here is virtually all the patients who have difficulties in quiet have more hearing loss and more difficulties understanding speech and noise. And virtually every patient that we see that, again, that has a word rec score less than 75% falls into this category, okay? In contrast, of course, people with, if you have somebody with less hearing loss and less difficulty understanding speech and noise, they always have excellent word recognition scores. And it varies a little bit through here, but I think this is the most striking part through here. If you have a problem in quiet, you have more hearing loss and more difficulties understanding speech and noise. And to my mind, this allows us to create guidelines. So we don't need to do word rec on everyone. You start with your quicksand, okay? You start with your test of speech and noise, and basically you only would do word recognition if your quicksand score shows greater than a 7 dB signal noise ratio and your high frequency pure tone average is greater than 40. I could tell you that across looking at our data with almost 6,000 patients, we have sensitivity and specificity values of this over 90%, which is really hard to do on a clinical basis with any as any of you know. I mean, and the other part is, we're not missing implant candidates with this. The people that we're missing, if we kind of go back and we look at this figure here, people that we might be missing with this criteria here, these are individuals maybe scoring 74%, 72%. We're not missing implant candidates. And so I would argue that this is the criteria that we should be using in terms of when to test word recognition and quiet. And the rest of the time, speech and noise should be our default test of speech perception. You can clearly modify this to use quick sense greater than 7 or PTAs greater than 40. It's just if that's the case, your sensitivity goes up a little bit, but so does your false positives, and you end up doing word rec on a few more people. But I'll tell you, this is our goal right here within Stanford. The paper that in which I laid this argument out, was recently accepted for publication in Ear and Hearing. So I'm hopeful this will be appearing soon, and we're gonna have a lot more speech and noise papers coming out. But our goal at Stanford, realistically, is to stop doing word rec on most patients unless they meet this category, and to do that within the next 6 months, ideally. Okay. And again, I would argue these protocols enable speech and noise to replace word recognition and quiet as a baseline measure. Okay. They provide data-driven guidelines as opposed to when word recognition actually should be measured. Okay. And I think that's important too. It's, people have talked for, it's interesting, the NU6 list that most people use in clinic were first published in 1966. In 1968, Carhart and Tillman, who published the NU6 list, saying we should be testing everybody in noise. But we're still using the same list from over 50 years ago. But the noise part is the sort of thing everybody's talked about, but it's like, what does it actually take to integrate it? I think here we've got data-driven guidelines as to what to do and when, and frankly, that also allows us to preserve the time that it takes. So this way we're not just having an audio suddenly take 90 minutes. And I think bottom line also, using this sort of approach allows the routine hearing test to be more sensitive to concerns of the patient. Because I think it's frustrating for patients to come in and say, yeah, I'm having trouble understanding speech and noise, and we never test them in noise. So it's just odd that we do bring people in all the time and we don't do measures that are sensitive to their problems as a routine part of our audiology. And I think that has to change. And I think we can change that in a time neutral manner just by stopping doing word rec for the vast majority of patients. I know, nice provocative statement right there, but I really ardently believe it, having looked at this data for the last few years. Now, here's the thing. I'm going to show you some other parts where we can use speech and noise to look at auditory function. Okay. And I'm going to show you pretty much, I'm going to give you a hint right off the bat. Speech and noise is better than word rec and quiet at flagging every single one of these issues. And frankly, I can think of very, very, very few scenarios where testing a quiet gives me more information than testing a noise. Well, let's look at pathology. Let's look at vestibular schwannomas. And this is we got the House Ear Institute. This is one of the legends in this regard. But when we think about vestibular schwannomas and we think about speech recognition, of course, the assumption is that speech understanding is going to deteriorate in the presence of a schwannoma. Okay. We know that this is not a shock to anybody. And so what many individuals and what we train audiologists to do is to look for asymmetries in word recognition scores as a potential flag for vestibular schwannoma. Okay, so that's great in theory. Now here's a quote from 1977 from Don Dirks, one of the fathers of audiology and one of the individuals who published some of the seminal work on looking at word recognition scores and vestibular schwannomas. What he says, and I want to quote, "The use of speech discrimination scores for differential diagnosis of retrocochlear pathology has never been highly successful because of substantial overlap in scores among patients with cochlear and eighth nerve disorders." Okay, and I imagine that many of you in your own practice, you see this. You could have times where yes, the word recognition scores differ, and we remember that, but there's many times where the word recognition scores are exactly the same, but the patient still has a schwannoma. Okay, and so this, to my mind, would argue that this isn't. We've known this for over 40 years that the basis for holding on to word rec it actually isn't very strong. So if we're just looking at your word recognition alone, it's not really very predictive of retrocochlear pathology. If you get a difference, it means something, but your sensitivity is often pretty low. Now, back in the day, what they used to do, particularly in the pre-MRI era, is they would compute something called a rollover ratio, which is what they would do is they would measure word recognition. And of course, the assumption is, well, if word recognition gets worse as the intensity gets higher, then that can be indicative of a retrocochlear pathology. The thing is, so we talk about this a lot in audiology, but to do this in the way that actually, looked like it meant something, requires 6 to 8 word rec lists measured at multiple presentation levels, and then what you compute the actual ratio that things fall off. Okay. And I don't know if your clinic is like ours, but anybody think of the last time they did 6 to 8 word lists on somebody at different presentation levels? I mean, that's just, it doesn't happen in modern practice. It's not realistic. And again, if you're getting a whiff of an issue, we're going to send MRI as opposed to send them down the hall to do 6 word lists or 8 word lists. So this is what it takes actually to kind of get reasonably good using word rec. But here's the thing: when we start testing patients in background noise, I will tell you that speech and noise is actually twice as sensitive to the presence of a schwannoma than speech and quiet. Okay. So what I'm doing is I'm plotting 2 graphs here. So one, again, this manuscript is in revision right now. We had some pretty favorable reviews, and I'm optimistic we're going to get this accepted pretty soon. But what we're plotting here, this is the word recognition score of an ear with documented vestibular schwannomas, and we're looking at 72 patients here with documented vestibular schwannomas. Okay, and then here, this is the contralateral ear with the word rec score, and basically anything along this solid line would mean the performance is basically the same across the two. And then, of course, the larger the circle gets, what we're doing is we're seeing more patients with those values. Okay, so what's striking here is, so anything below this line would mean they are doing worse in the ear with word rec. And so what's striking here, so yes, many individuals do a little bit worse with word rec, but most individuals, by and large, are still doing quite well. So using some of the classification systems that we've seen in the literature for word recognition scores in the presence of a schwannoma, 56 patients had basically the vast majority of these had excellent word recognition scores. So basically falling in this range right through here. And we really only had, 23% of patients had a word rec score less than 70%, falling in one of these categories. So most of these patients are really still doing quite well. And I can tell you, I've got data suggesting that maybe only 1 out of 3 patients show a statistically significant difference in word recognition scores in the ear with the schwannoma versus the ear without one. So 1 out of 3. And here 23% had a word rec score less than 70. Now, in contrast, when we start looking at speech and noise scores, the vast majority of these patients started having some sort of deficit understanding speech and noise. So you can see here again, this is your the quicksand SNR loss in the ear with the schwannoma. This is the contralateral ear. This is a better ear. Anything below this line would indicate better performance. Okay, worse performance in the ear with the schwannoma. And what we're seeing here, of course, is there's a cluster of patients who do equally well on both, but we have lots of patients are far more likely to have difficulty in the presence of a schwannoma than difficulty on the word recognition task. And again, well over twice patients had a significant deficit in the speech and noise task. I could tell you, so when we plot sensitivity and specificity values for these sorts of things, comparing it to PTA differences, okay, versus word recognition differences using AAO guidelines of greater than 15% or less than 80% each ear, using a 95% confidence interval for 2 lists on a quicksand, or using a speech noise image signature that's a little larger, 5 dB. What you can see, the area under the curve, okay, meaning how effective is word recognition and predicting it, it's basically literally only slightly better than chance. The sensitivity is very low. The specificity is high. So if you got a difference, it probably means something, but you're missing a ton of people. Okay. In contrast, the sensitivity and specificity values are actually slightly better. It's a small but statistically significant difference for speech and noise, even relative to differences in pure tone asymmetries. Okay, so this is, and clearly pure tones are much better than word rec. Speech and noise are much better than word rec. Again, these are very similar, the pure tones and the speech and noise. This is slightly better if we kind of use our best criteria. And we would argue that your most accurate measure is looking at speech and noise differences of 5 to 60 dB, signal noise ratio between ears, would be like a good red flag in terms of what a patient that might have a schwannoma at this point. So again, would argue that here, by looking at speech and noise abilities, we are twice as sensitive to an auditory pathology than testing in quiet alone like we've been doing, and we're more accurate, okay? So not only better characterizing patient performance, okay, doing tests that line up with what they're doing, we're better at flagging pathology than what we're doing by traditionally looking at word rec, okay? What about when patients feel like they're having a problem, okay? Perceived handicap. What makes them come in the door in the first place, okay? And I'll tell you again, speech and noise lines up better with perceived handicap than testing in quiet. And frankly, I'll give you a preview. Testing in quiet tells you nothing about how patients perceive that they're performing. So if you do that, so for example, if you guys, I don't know if you're familiar with the SSQ, stands for the Speech Spatial Quality Questionnaire. We use the short form version of it, but this is basically a series of questions where a patient rates their performance on a scale of 1 to 10 in terms of how well they think they are functioning in their day-to-day life across a variety of domains. And some of that's speech and noise, some of that is how to sound quality sound, and some of that is your ability to localize sound, okay? And no shock, no surprise on this. So this value right here, this is represents the average of like about 150 young normal hearing college students, basically 22-year-olds, you know, your optimal scenario. This is 2 standard deviations from that, okay? And this is data from about 2,000 patients in our clinic who had symmetric hearing between ears. And what you could see, no surprise, that as your quicksyn, you know, your speech and noise abilities gets worse, people's perceived handicap gets worse. And what's telling is the only people that fell within this kind of range of what we might consider to be normal on a quicksyn are individuals, or I'm sorry, normal on the SSQ, meaning I don't think I have a problem according to my ratings, okay, compared to at least young normal hearing college adults. The only people that fall within this range are individuals with normal speech and noise scores. By the time we start getting to mild speech and noise problems, moderate or severe, you know, on average, these individuals are clearly falling outside of these normative values you're seeing from perfect individuals, perfect hearing college students that don't feel like they have a problem at all. Now, I've shown you these nice bar graphs. The raw data themselves, of course, are a lot messier. And I'll tell you that questionnaire data on patient perceived handicap are extraordinarily variable. And this, you know, I laugh when I look, there's a lot of SSQ studies in the field, but people don't necessarily show what the raw individual data look like. They show these nice clean figures that look like this and say, oh, okay, these questionnaires are great. And if you measure them in actual patients, it's a different story. There's no surprise here, but you know, but on the whole, you could see the same general trend. So this is the mean performance right here. And what you're seeing are all the individual data points. So do we have individuals with, you know, even a moderate speech and noise deficit who still feel like they're doing okay? Sure. Okay. We have lots of them that still feel like they're doing poorly. And we have people who score perfectly normally on a quicksyn, but who really think they're having problems, just not as many of them. And of course, this is a scatter plot showing this relationship here. Now, if we look at hearing loss, we see similar trajectories when we look at hearing loss. Again, rock normal, borderline, mild, moderate, moderately severe, and severe. So you can have individuals with mild, moderate hearing loss who still feel like they're communicating pretty well, and others that feel like, you know, but the likelihood of you saying that you have a problem starts to go way up once we start getting into the mild to moderate hearing loss range. And individuals with normal hearing, you have many of them that feel like they do just fine, and you have many of them that feel like that they've got a big problem, okay? So hearing loss and speech and noise abilities track similarly in this regard. But word recognition really has a poor relationship. And this is the only one that we looked at that did not have a statistically significant relationship with perceived handicap. as measured by the SSQ. And that's in part because, most people do just fine on word rec. Okay. They just, when we look across our data, um, over about 86 to 88% have a word recognition score that's 88% or higher. Okay. Which is, again, is striking, is, these people are coming in with a problem, for some one reason or another. But if you make the speech loud enough, they don't have an issue with it. Okay. So it's not a surprise to me then that given that some individuals with good word rec would feel like they do just fine, and some would feel like they've got a problem. But I could tell you there's no relationship between your performance on these measures and how will people think they're doing in the day-to-day life. And when we built the statistical model to kind of look at this, we put a number of factors in: pure tone average, age, quicksand abilities, word recognition scores. And I can tell you, your degree of hearing loss, your speech and noise abilities, and age all predicted how well people thought they were doing in their day-to-day life. Your word recognition score had no predictive power in terms of how people thought they're communicating the day-to-day life. Which again, so remember, so I can predict if you're going to be good or bad on word rec. It's not as sensitive to important pathologies like vestibular schwannoma, and has no bearing on how people communicate in the day-to-day life. So I would make an argument again. This is, once again, the argument in favor of keeping word rec grows weaker and weaker by the day if you actually look at the data. If we look at other factors, looking at age, okay, the default assumption that we have is that, well, yes, as people get older, your speech understanding gets worse, okay? And that would be true both for word recognition scores and quiet and for speech and noise, okay? And that's the default assumption. But actually what our data are showing across a large number of patients is that once you start controlling for the effects of hearing loss, we don't see an effect of age anymore on word recognition and quiet. We only see effects of age in speech and noise, okay? So here, what I'm doing is I'm plotting your speech and noise abilities. I've broken patients into different degrees of hearing loss. So basically, rock normal, borderline normal, mild hearing losses, moderate hearing losses, okay? And then we've plotted the age of the patient by their speech and noise ability. And again, better performance at the top, worse performance at the bottom. If this regression line slope starts to go negative here, that would mean that people are doing worse as they get older. And across, what's striking, so first across all four, as we increase the amount of hearing loss, or basically across all levels of hearing loss, there is a significant effect of age on a quicksand that we're not, there's a significant effect of age on a quicksand. And what's interesting is the size of this effect seems to get larger the more hearing loss you have, okay? So you can see there's a small negative trajectory for individuals with perfectly normal hearing. And then we get down to like mild hearing losses, moderate hearing losses. This trajectory starts to get steeper and steeper. Lots of variance still, okay, because individual data are messy when you look at it across thousands of patients. But I could tell you that no matter what degree of hearing loss we look at, we always see a decrease with age, even in individuals with perfectly normal hearing, okay? Now, that's not the case when we look at word recognition and quiet. So again, across all of these, you can see the slope of this regression line is completely flat when we look at all these. Now the intercept of this regression line goes down because the average performance goes down, but we're not seeing an effect of age anymore after we account for the degree of hearing loss. So, our default assumption that word rec scores get worse with age actually doesn't really kind of hold water once you start looking at the data. The effect of age that we're seeing is really just an effect of hearing loss. But once we start accounting for degrees of hearing loss, age doesn't have much of a relationship for speech understanding and quiet, but it has a big relationship in terms of understanding speech and noise. And for those of you that deal a lot with the stats, it's hard to not get a statistically significant regression line when you load 1,000 patients into it. And that's one thing it's striking for us. It's like, I kind of thought we'd see some sort of small effect. But even loading, hundreds, thousands of patients into this, we just don't see this effect once we account for the degree of hearing loss. So age decrements in word rec score are really just hearing loss decrements. But speech and noise decrements, there's something independent going on of degree of hearing loss, speech and noise decrements with age. Okay, so again, I'll lead you kind of with this before I go to something really provocative here that I'm very excited about. I will tell you that in terms of routine clinical issues that we think about, I would argue that speech and noise is more effective than word recognition in quiet. It is more sensitive to the effects of hearing loss. Okay. We could do just fine in quiet, but have significant problems in background noise. We are more sensitive to the effects of pathologies, important ones like vestibular schwannomas. Okay. We're more sensitive to the effects of aging. Okay. Which again, these are issues that our patients face as they get older. Okay. We could better predict how patients feel like they're doing in their day-to-day life. All right. Word recognition and quiet can't do that at all. And frankly, again, I can predict if you're going to be good or bad at word rec. And if I can predict you to be good, it's a waste of time. For example, our data show that if you basically have less than a moderate hearing loss and less than a moderate deficit, speech understanding and noise deficit, the likelihood of you having a word rec score of 90% higher is like 99.8%. Okay. It's a waste of time. Any second you spend doing word rec, if you don't have at least a moderate deficit in speech and noise or moderate hearing loss, word rec's a waste of time. Even if you're doing difficulty weighted lists, anytime because it's well over 99% likely that it's going to be perfectly normal. Okay. And again, our goal at Stanford, the first paper, once it hits publication, especially when some of these others come out too, we're going to try to transition away and only do word rec if somebody has greater than a moderate speech and noise deficit and greater than a moderate hearing loss. Now, this is exciting for routine clinical practice, but I would argue that we can go further by looking at speech and noise, and it opens up doors to doing new things and stuff that really kind of matters within the world of our patients. Okay. For example, I think we can observe deficits in neural encoding. Okay. So when we talk about cochlear synaptopathy, there is zero relationship between performance and quiet in patients with synaptopathy. Okay. There's data out there to suggest that there are deficits understanding speech and noise. I'm going to come back to this point. Identify patients at risk for cognitive issues. Okay. And then I'm going to spend a little time talking about this because I think this is absolutely crucial. Assays of listening effort. This is another important part of the patient experience. And I can guarantee you, look, I'm a scientist as well as a clinician. I do not know of a single assay of listening effort that is done in the research world that looks at performance in quiet. Nobody's going there. Okay. Again, the field it's because we know that it has zero bearing. But let's talk a little bit about why I think speech and noise can get at these things. Okay. So when we look at what does it take to understand speech and noise, okay, it's really a series of factors. The first and most important, of course, is can you hear it? Audibility. Because if you can't hear it, nothing else matters. Okay. That's just it. If you can't hear it, nothing else matters. But once you can hear it, there are factors beyond this. So Plump, in a series of papers in the 70s and late 80s, kind of laid out this argument. This framework is still kind of widely used today. So he described it as audibility, and can you hear it? And then he talked about distortion, which he used as factors beyond audibility. And these factors beyond audibility can be largely broken into two categories. So first is peripheral encoding, bottom-up issues. And this would be things like, I think, like cochlear synaptopathy, or it could be things like, increased spread of excitation along the basal membrane. Okay, factors like this, things that happen within the cochlea. As I like to tell my patients, when you lose your hearing, you don't just lose your ability to hear soft sounds. There's a whole raft of other things that happen within the inner ear that results in your brain getting a slightly muddier signal. Your ability to tell one pitch from another starts to get worse, even when you make it louder. And hearing aids and other things, they can't necessarily fix that. So there are deficits in the peripheral encoding coming up, but understanding speech and noise is also driven by executive function, top down, your brain. How effective is your brain at making use of that information? And so when we start looking at speech and noise, we can, yes, we're influenced by audibility, but we can, depending upon how we set up our test, we can look at factors beyond audibility, whether peripheral issues, or we can start to tap into central issues as well. Okay, now think about this classic work from Frank Lin. I think many of you are probably innately familiar with this. We're basically showing that the risk of dementia goes up considerably with untreated hearing loss. And so if you have, the more hearing loss we have 2, 4, 6, 8 times the risk of developing cognitive decline as we get older. All right. Now this is important, and this clearly this has been a very provocative concept that we in the field are very aware of. But the thing is, it's not like every patient with hearing loss develops dementia. Okay, so I always, to my mind, I kind of, when we talk about, well, we want to screen everybody's hearing, which is important, but I think a better question sometimes is, well, which patients with hearing loss are really likely to be at issue? When I look at our own data, they say, okay, well, which patients at hearing loss are likely to have an issue? Look at this. So let's go back to our original data across almost 6,000 patients. You take patients with a moderate hearing loss. Some of these people still do quite well in background noise, and some of these people can't function at all. Okay, so we got the same amount of hearing loss. Some people do well, some people can't function. So maybe these individuals kind of down on this end of the spectrum, maybe these are the ones who are more likely to have some sort of either super threshold deficit or a deficit, within their cognition that inhibits their ability to do the task. Okay. Now, what's interesting, so then we've gone and looked at across our data set, looked at literally, took a group of 3,000 patients who had speech and noise done across varying degrees of hearing loss that had no cognitive decline, diabetes, no hypertension, basically nothing with any sort of vascular component. We stripped all that out. And we compared it to a group of individuals with a confirmed diagnosis of Alzheimer's, dementia, mild cognitive impairment, things of this sort, okay? And comparing the two. And what's striking is that, for individuals, across all degrees of hearing loss, individuals with a confirmed diagnosis of a cognitive issue perform significantly worse. Okay. So again, we start looking at mild hearing losses, we get a 2 to 3B difference, smaller here in the moderate, but we're starting getting, across the board, we're getting, 1 to 3 dB differences. Okay, to our patients with a cognitive issue perform on average worse than patients with no cognitive issues, no vascular issues, nothing of that sort. Okay, so we can see these things when we start to test patients in noise. But if you, okay, so here's actual, these data look nice. I want to stress that, but I gave you the bar graph because it looks prettier here. In the real world, of course, there's a lot of patient variability. So you can still see consistently, like these values are consistently, say, like 1 to 3 dB less, okay? But there's still a lot of variability within this. I'll come back to this point. But you can see these differences on average when we're looking at speech and noise. You cannot see them when you're looking at testing patients in quiet. So we look at patients with no cognitive issues versus a patient with some diagnosis of mild cognitive impairment. They perform the same on measures of word rec. Okay, and you could see the same thing here. We just really can't separate out differences in performance. So our conventional word recognition in quiet, I mean, not only are we not good at picking up other pathologies, but we're not sensitive to some of these central issues that really are facing our field today. And again, you could see the same thing here. When we start looking at patients with no cognitive issues, mild cognitive issues, the spread of performance is largely the same. So I would argue that we can, this central issue of cognitive decline, we're going to be far better off picking this up with speech and noise and have the potential to do that. And there's advantages of using a test like speech and noise as opposed to, say, having audiologists do cognitive screeners, because now we're still within our scope of practice. Now, the differences here are not large enough yet, okay? I know we have a selection bias, because my staff, they're not always getting the speech and noise on every single patient that comes through the door, okay? And so they're only doing it on patients that think they can do it. So if you're only doing it on patients with a cognition think they can do it right off the bat, you're not catching some of the worst ones, okay? So I know there's a bit of a selection bias within this. And frankly, I'll be candid, there are things we can do within the QuickSyn or other speech and noise tests that I think can make it more sensitive to cognitive issues. Conversely, if we take another, flipping around a little bit and say, think about synaptopathy, other parts like this, I would argue in the future, and this is one of the things that we are actively working on at Stanford, okay? I'm actively working on what's a good speech and noise test that might be more sensitive to cognitive issue, and what's a good speech and noise test that's more sensitive to cochlear synaptopathy, this concept of hidden hearing loss, okay? And if you want to look at patients, something like this, I don't think a sentence-based test is a way to go. I would argue that a speech and noise test with minimal semantic cues, very narrow ranges of signal noise ratios are probably best. And the sentence based tests that have a broader range of signal noise ratios and, more important, greater cognitive contributions are probably suboptimal. So, the same way that, if physicians, you regularly pick the test that is likely to yield the most information about the patient, I want to create a world where audiologists have that power to be looking at what's the right speech and noise test to do for this patient based on their degree of hearing loss, based on the degree of symptoms, and based on what we're suspecting. And I think that I could tell you that by tailoring how we do speech and noise, we can tilt it more toward the peripheral, or we can tilt it more toward the central. So if we're worried about a cognitive issues, we're going to look at one set of tests. If we're going to look at some sort of synaptopathy-based issues for patients with better hearing, we're going to steer toward a different set of tests. And that's, so my hope down the road is, and this is something we're working on. And again, I want to make test batteries that are more sensitive to the patients and give us as hearing healthcare professionals, physicians and audiologists, more information and better information. So in conclusion here, I want to say that I think when we start looking at routine audiology function in the test battery, that speech and noise is an optimal tool to assess auditory function. Okay, very simply, it gives information that word rec cannot. All right. And we can do this without interrupting or interfering with clinical practice in any way. Plus, it's more sensitive to pathology. It's more sensitive to perceived patient handicap. And I'll tell you that I think as we scientists like myself and others further refine these tests of speech and noise, I think that we're going to be able to open up new doors in terms of diagnosis and rehabilitation. Identifying kids or adults at risk for executive function disorders. For example, we did a review, within our pediatric practice. We're trying to get this published right now. But children with some degree of hearing loss are 4 times more likely to have a diagnosis of ADHD, okay, than a child with normal hearing. So this is now it's not, there's a lot of factors that could go into that, but the issue is that these sorts of executive function issues are likely to be present in children or in adults with hearing loss. And our current test battery, where we're just asking people to repeat monosyllabic words, doesn't get at that, okay? I think we can better assess listening effort. I think we can better track synaptopathy related disorders. And ultimately, really kind of lead toward just like really modifying the test battery to do what it should be doing, which is addressing patient concerns and giving audiologists, physicians better information to manage their patients. So with that, I have an amazing team of audiologists who've worked with me on a lot of these projects. I got buy-in from a lot of people in order to collect these data. And then of course, I have to thank that my physician partners at Stanford, Dr. Stankovich, Dr. Jackler, Dr. Blevins, really, they have been absolutely, Dr. Jackler and Blevins in particular have been very supportive of this work from the beginning when I started this several years ago. And their guidance and insight has become very valuable.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.